So I've selected some digestive tract diseases cases to discuss today with you. This is a history of 2 days severe abdominal pain and fever. What's the first you think if you have pain and fever? The first you think is inflammation, all right? So where is the pain? Where is the pain located? You see, it's right here on the right side of the lower abdomen, and if you put the patient to sit in a particular place and you press, the pain worsens, it becomes worse. So you have the white blood cell count, it is elevated, and neutrophils predominate. So what is this? How do you evaluate this finding? You have leukocytosis with neutrophils predominated. This is a sign of what? Acute inflammation. And taking into account the location, it's probably appendicitis. That's right. So you have to remove the acutely inflamed appendix, because what will happen if you leave the inflammation there? This is part of the large bowel. So there is the inflammation starting from the mucosa, probably some sort of ficus stone is there and erodes the mucosal cylindrical glandular epithelium, and this causes ischemia. Ischemia is necrosis, it's damage, so inflammation starts. And we have the neutrophilic exudate, and if this persists, granulation tissue is organized, inflammatory granulation tissue, and this follows all the layers of the appendiceal wall, and it may rupture. And all the inflammatory exudate will go into the peritoneal cavity, and this will be a very life-threatening problem of acute peritonitis. All right? So if you have appendicitis, the solution is immediate surgical excision of the acutely inflamed appendix. And there are some bands. That means this is the left shift. You remember we said in inflammation, after there are so many neutrophils coming out of their storage in the bone marrow, and some immature cells also leave. That has nothing to do with leukemia. It has to do with the acute inflammation stage. So what do we see here? We can see that what type of epithelium do we find in the mucosa of the appendix? It's the same that we find in bronchi, in the stomach, in the bowel, in the endometrium. It's the same type of mucosal epithelium. What is that? That you see in the right part of the image being there preserved. What type of epithelium is this? What does it form? What does it form? Glands, so it's glandular, cylindrical, glandular epithelium. However, there is here on the top that the mucosa has been eroded by the inflammation. Here is where the damage was made. So we see no glandular elements. We see no glandular elements. And this is an erosion if it is quite superficial. But if we have the formation of inflammatory granulation tissue, this is officially an ulceration. All right? So if during an inflammation phase the mucosa is destroyed, this could be an erosion. But if you find on down the erosion the formation of new capillaries, mixed inflammatory infiltrates, and this shows signs of exudate organization, this is inflammatory granulation tissue, and this is an ulcer, not longer an erosion. So this is the acutely inflamed appendix. And of course, there are other diseases which we'll learn in internal medicine that can have similar signs. So you have to be sure that it is appendicitis before doing surgery. And we had the neutrophilia with the left shift, with some immature cells leaving the marrow as well. And of course, we have the acute phase proteins elevated in the serum. Which are the most common acute phase proteins that we look for? So that we understand that the patient is in an inflammatory status. Which are they? What do we look in the serum? Which are they? Yes? CRP. It's CRP. I think it's also fibrinogen. And there is another marker. All these are not so specific for inflammation. They can increase in other circumstances. However, it's the first you think. It may be so, it may not be so. So I think it's fibrinogen, CRP, and you have the erythrocyte sedimentation rate, which is increased. In some cases, these markers can be increased, for example, in cancer. So they are not absolutely specific. But if you find all of them being increased, it's most probably acute inflammation. These are the acute phase proteins of inflammation. Oh, look here. Here is the, I think it's the bowel. Yes, it's a 20-year-old woman, a young woman, diarrhea and fever. So, of course, you have to think that this could be infectious colitis, because if there is an imbalance in the flora of the microenvironment of the bowels, perhaps one microorganism grows more than the others, and it can cause inflammation because there is a disturbance in the natural flora of the bowel. However, in this case, stool culture has no pathogens. So we eliminate the possibility of infectious. If it was an elderly patient, you could think of another type of colitis, which is very common in elderly patients because they have atherosclerotic vessels. And what would this be? What would this be? In an old patient, if he has bowel disturbances, it could be ischemic colitis, because older people have atherosclerotic vessels which can become stenotic and sometimes occluded. Of course, it's not a case that you have an infarct, like an acute complication of atherosclerosis in a diabetic patient, like the mesentery artery. Smaller arteries cause problems of blood supply to the bowel, and this is an ischemic colitis. However, in a young patient, what you think of would be idiopathic inflammatory bowel disease, which has mainly two types, Crohn's disease and ulcerative colitis. So this is the case here, that we have involvement of the terminal ileum, which is quite characteristic of Crohn's disease, and you have a skip by skip involvement of areas throughout the gut. There is not continuous inflammation like in ulcerative colitis. You have an inflamed area, then you have a normal area, then another inflamed. So if you take biopsies, inflammation is not in all your specimens. It has some sort of localization, the inflammation. It's not dispersed in all the specimens you examine under the microscope. And the other characteristic of Crohn's disease is transmural inflammation. Ulcerative colitis is inflammation of the mucosa of the bowel. On the contrary, Crohn's disease has transmural inflammation. As you can understand, this can cause problems, because if you have transmural inflammation from two neighboring loops of the bowel, then a fistula may be formed because the inflammation tears the wall. So when you have inflammation like a fistula, this affects the peritoneal cavity. And do you remember what type of inflammatory exudate is formed in areas when we have layers with mesothelial lining? Do you remember this, inflammatory exudate? What is it rich in? What is substance is it rich, that exudate that we have in the pleura, in the pericardium, in the peritoneum. Like, this is a complication of Crohn's disease. A fistula was formed between two adjacent bowel loops, and this caused irritation to the peritoneal lining of mesothelium, and the inflammation affected the peritoneum. What is there in this exudate? There is a substance in this exudate that this is very rich in such inflammatory exudates. You remember it? And what it causes, what it may cause, most importantly. What do you think? It's the same in pleura, pericardium, fibrin, and it causes strictures. So if you have strictures compressing the bowel from the outside, the content can no longer leave the bowel, so you have obstruction. It's one cause of obstruction. A fibrin-rich inflammatory exudate which persists and forms strictures. So do you think that you should have the... If he has strictures, yes, he has strictures, of course he will have vomit. How's that? You will have... How is that called? Vomit is with blood. Hematemesis. So you look in the hematemesis, and if it comes from the bowel, the color will be brown. Why? Because bile has entered the bowel. So if you have, and you see the vomiting, it will be brown. And if it's from the large bowel, it might have ficus as well. So there is another case, however, that the vomiting is brown. When you have gastrorrhagia, when you have bleeding in the stomach, and it's not so recent that it makes it look red, but it stayed in the stomach, and it became brown from the gastric acid, and you have this sort of hematemesis appearing brown. So you have to make an X-ray, and if you see distended bowel loops, this will be obstruction. If you don't see this, it might come something from the stomach. For example, an ulcer that is causing the bleeding. Yes?
Can you say again the type of inflammation we have in ulcerative colitis? Not transmural, what is it?
This is Crohn's disease, right?
Yes, yes, but you said the distinction between...
Yes, in ulcerative colitis, the inflammation is confined to the mucosa. On the contrary, in Crohn's disease, it is transmural. That's why it causes so many complications, and perhaps these complications are surgically treated. When you have an inflammation, surgery is the not first thing you think of, like when you have a neoplasm. However, if the inflammation has complications, then surgery is necessary. Yes? All layers, yes. It comes, it starts from the mucosa, submucosa, muscular, subserosal, serosa. All layers. That's why fistulae are formed. And it may cause this sort of inflammatory exudate and strictures. So the risk of malignancy on such an inflamed bowel is not so great like in ulcerative colitis. And any part of the digestive tract can be involved by Crohn's disease. This is another case. Another case of, you see, 15-year history of diarrhea that comes, leaves, comes again, leaves again. So such a long history. Which sort of colitis excludes? If you have a patient and he tells you that he has all these episodes of diarrhea for 15 years, what can, it could not be ischemic because he's not so old, it cannot be infectious either. 15 years infectious colitis, where is he living? Okay? So what do we see here? This is a colitis that it is confined to the mucosa, and it has a continuous involvement of the large bowel only. Remember, Crohn's disease was in the terminal ileum as well. and it had skip-by-skip lesions. No, this is not the case here. Here we have a continuous involvement of the mucosa, starting from the rectum and going further, sigmoid, all the other parts of the large intestine. And how could you describe these findings on the mucosa? How could you describe these findings? What do they look like? They look like protrusion, that they protrude in the lumen of the bowel. And how can they be called by the gastroenterologists who performs the colonoscopy?
Ulcers.
Yes, if they did not protrude, they could be the margins of ulcers. However, they do not have a necrotic center. So they are not ulcers. What can they? If you see something that protrudes in the lumen, how does the endoscopist say that it is a polyp? So these look like polyps. However, they are not true polyps because they are not neoplasms. It's granulation, inflammatory tissue that gives this pseudopolypoid appearance to the bowel mucosa. And this is ulcerative colitis. And you see cramping pain. And the patient had a colectomy because there is a complication, not similar to those like Crohn's disease that we said strictures, fistula. No. In ulcerative colitis, the most important complication is when the mucosa becomes severely dysplastic. If you see dysplasia in the mucosa and high-grade dysplasia, what are you afraid of? What may complicate this inflamed mucosa? If you see dysplasia and high-grade epithelial dysplasia, what are you afraid of? What may happen there? What may happen? Dysplasia is a precursor of cancer. And in this case, cancer, complicating ulcerative colitis, will be multifocal in many places. So you think that you may think of removing, of resecting the bowel to exclude this cancer development. You see the pseudopolyps. All right. Here we are. Now, in this colonoscopy, we see two lesions, very, very characteristic. Which one is the one that protrudes into the lumen? And how could you describe the other lesion? How could you describe the other lesion? Which is the one that has an exophytic growth? Which lesion is that? This is the one that appears some white. Yes, yes. And it's very smooth, I can see. So you see that it protrudes. It's an exophytic lesion. It is very smooth. This does not favor malignancy. However, you must resect it because this is not a pseudopolyp like the ones we saw complicating ulcerative colitis. This is a true adenomatous polyp. This is a benign neoplasm of the mucosal epithelium, of the glandular epithelium of the large bowel. So you should resect it so that it does not become cancer. Because adenomatous epithelium in the gastrointestinal tract has always some degree of dysplasia, either low grade, which is not so dangerous, it's not totally innocent, it can be complicated by invasion. However, not at such an extent, such as high-grade dysplasia. High-grade dysplasia is the precancerous lesion. So when you see a polyp, and it is a true polyp, because I say a true polyp because there are some other polyps which only rarely are complicated by cancer development, and they are quite frequent in endoscopies, colonoscopies. These are hyperplastic polyps. Hyperplastic polyps have a very decreased malignant potential. It's not so worrisome. However, adenomatous polyps, or adenomas, that means benign neoplasms of glandular intestinal epithelium, should be resected, and you have we'll have the polyp. And what do we look? Is it a pedunculated or a sessile, a flat adenoma? We check the margins so that they are not dysplastic, because if you leave dysplasia in the patient, the problem will persist. We see the greatest dimension in centimeters, more than 2 centimeters, are suspicious that they have been malignantly transformed in cancer. You see the degree of dysplasia, high-grade dysplasia is precancerous, and then you see at the pattern of the histologic pattern of the neoplastic benign but dysplastic epithelium, it forms papillae in more than 75% throughout the polyp. That's a papillary adenoma which can develop cancer more easily than other adenomas in which the villus compartment is lower than 75% and has a tubular patterns forming glands. So these are what we see in the polyp. However, there is something else evident here in this colonoscopy image, apart from the exophytic lesion, which is an adenomatous polyp. Apart from that, what else do you see? What else do you see? Nearby. What do you think? How could you describe this? Yes?
Fistula hole.
Yes, there are some holes, some downward holes from the mucosa. These are diverticulae, and they are very common as well. And if they break, they can go. These are true diverticulae. That means you have all the layers beginning from the mucosa, projecting throughout the wall and reaching the subserosal fat tissue. So if some of these is filled with ficus and it erodes, inflammation may be called, and this could be diverticulitis. And of course, if they are down the wall, that is a cause of peritonitis. Like we said in appendicitis, all inflammation that reaches serosa, that means the peritoneum, is a cause of acute peritonitis, which is a very dangerous condition, and the patient must go to surgery. They should fix the area where the peritoneum has been eroded, and they'll clean the peritoneal cavity from the inflammatory exudate. That is called lavage, I think. Lavage. I think that's how it's called. So these were diverticulae. And what do we have to stress from a clinical point of view? All these lesions, diverticulae, inflammation, and neoplasms, cause blood loss. Inflammation because it destroys the mucosa and some blood vessels give hemorrhage. And neoplasms can cause blood loss because if it is on the left part, then the ficus is formed as this develops exophytically. As the ficus passes, it erodes the superficial part of the adenoma, and it bleeds, and it gives blood. The same can happen in diverticulae, when we have ficus occluding the hole that you see there in the image, and erodes the mucosa, and this causes blood loss as well. So this can be manifested with anemia due to loss of iron. That means microcytic anemia, which affects MCV of the blood cells. And from a clinical point of view, the blood loss that is related to neoplasms, benign such as adenomas, and malignant such as carcinomas, only rarely is manifested grossly. That means if you see blood on the ficus, you see it with your eyes, then it is most probably related either to diverticulae or hemorrhoids. Of course, in the latter case, where hemorrhoids is the lesion, you'll have blood on the toilet paper as well, because these are the veins of the lower rectum that bleed. So if you see blood, most commonly, it's not from neoplasia, because neoplasia causes occult blood loss. So you have to examine the stool and see if there is hemoglobin in the stool. That's why you give the screening test. Do you have your parents here in Greece, or are they abroad? Because the Ministry of Health has sent screening, for screening reasons, blood tests to perform the general population, about 50 to 65. And if the test is positive, then you go to the gastroenterologist, and of course it's not obligatory that it is caused by cancer. An inflammation can cause blood loss, all right? So you'll have the colonoscopy. So those were these common lesions in the bowel. Now here is, you see, the screening test. They found this adenoma. This is a true neoplastic polyp, a true, not like the pseudopolyps we saw in ulcerative colitis. So this adenoma, is it sessile or pedunculated? Pedunculated means it has a stalk. Sessile means flat. What do you think? It has a stalk. So what do I have to do when this is resected? I have to check the stalk if there are neoplastic elements within the stalk. Because what is the stalk in such an adenoma? The stalk is the submucosa arising with the mucosa. So if you see true invasion, that means neoplastic elements, glandular neoplastic elements invading the stalk of this adenoma, this is malignant transformation. And in this case, you'll think that colectomy is, may be performed. However, if it is well excised and the margins are free, there is no high-grade dysplasia, and you don't find tumor emboli in the stroma, in the lamina propria or the submucosa, then colectomy is not so mandatory. However, it is of crucial importance to see the stalk, that means the submucosa, because when neoplastic elements enter the submucosa of the bowel wall, this is malignant transformation. So you think of colectomy. Pay attention, please. It's not the same in gastric mucosa. If you have a neoplasia in gastric mucosa that breaks the basement membrane and invades the lamina propria, this is also malignant transformation. You do not have, for gastric neoplastic lesions, you do not have to wait and say that they are cancerous when they reach the submucosa. No, because I think you all know the structure. What is the mucosa? The glandular epithelium and the lamina propria. And which is the margin between the two? Basement membrane. So, you have a neoplasia arising intraepithelially, that means above the basement membrane. It breaks the basement membrane and enters the lamina propria. For stomach, this is malignant transformation, and you have to perform gastrectomy so that the gastric cancer is early, and the patient has a good survival interval. Why do you do that? Because the lamina propria of the gastric mucosa has many lymph vessels. So such an early gastric cancer, early is called when it invades lamina propria or submucosa, it can be followed by lymph node metastasis. So you have to perform gastrectomy so to stage the disease properly. In the large bowel, the lamina propria of the large bowel mucosa does not have so many lymph vessels. So the possibility that an intramucosal carcinoma, what is an intramucosal carcinoma? It's a carcinoma that has broken the basement membrane, thus it's no longer intraepithelial, because what happens above the basement membrane is an intraepithelial neoplasia, a dysplasia. What breaks the basement membrane and enters the lamina propria is an intramucosal carcinoma. In the bowel, there is not high possibility that it has given nodal metastasis. So you treat it conservatively. You just resect the lesion, not the whole colon, the part of the colon with the lesion. However, as we said before, if in the bowel the neoplastic cells break the muscularis mucosae and enter in the submucosa, then you think of colectomy. Has that been made clear? In gastric cancer, T1 stage means invasion in the lamina propria. In large bowel cancer, T1 stage means invasion of the submucosa. Different staging. The same T1 for both, but different locations in these organs. So that was a polyp, and we said what we look in a polyp, and the genes involved, of course, and some risk factors. Here is the adenomatous epithelium. How can you tell that it is dysplastic? How can you tell that it is dysplastic? What are the morphologic signs of dysplasia? What do you think? Why is this epithelium not normal? It comes from a polyp, a true neoplasm, an adenomatous polyp. Yes, please. It's hyperchromatic. It has many nuclei, which are pseudostratified, and they leave the basement membrane compartment where the normal glands, nuclei reside. In normal glands, all nuclei should be close to the basement membrane. In dysplastic epithelium, they grow, become bigger in size, because we have an imbalance in nucleatocytoplasmic ratio. That means the nucleus becomes big, but it's not only that it becomes big, that's why it gives the dark color, it stains with hematoxylin. But it's also pseudostratified. That means that it reaches, have a look here, it reaches the luminal border, the gland's lumen. So this is an adenoma with low-grade dysplasia. Because to define high-grade dysplasia, we must have architectural alterations, architectural lesions similar to cancer. But since high-grade dysplasia is morphologically identical many times to cancer, how can you discriminate that this complex architectural structure is high-grade dysplasia and this similar architecturally complex structure of hyperchromatic cells is cancer? Yes? That's, exactly. It's where you see it, not only what you see, because if you see the complex structures in the mucosa, they are not cancerous, even though they may have broken their basement membranes. Why? Because we said lamina propria of the bowel mucosa does not contain lymph vessels, many lymph vessels. If you see such complex atypical structures breaking the muscularis mucosae and entering the submucosa, the same lesions are cancer. Okay? I think, shall we do the GI lab together? We'll see the slides. We'll see the slides of this. Tomorrow we'll have the circulatory, the lab together. I gave you the link with the slides because it will be practical. You'll have the slides on your devices, and you'll try to find what I show you in the image. It won't be theoretical. I'm allergic. Oh, allergic to theory. No, don't want that. Yes?
We said earlier that in neoplasia mostly we find positive occult blood.
Yes, that means you don't see it. You don't see the ficus become red. You have the hemoglobin test. Yes.
Also here in the adenoma we found it.
This is neoplasia. Adenoma is benign neoplasm. Cancer is malignant neoplasm. Yes. So, next. Next case. This is cancer. And what do we see in this cancer? We see that it protrudes in the lumen. However, it's not so homogeneous as the adenoma we saw previously. Why? Because its surface is, what is the surface of this lesion? Which differentiates it from the other lesion we saw, the adenoma. What's the surface? And it's so irregular. It's ulcerated. Okay? When you see an ulcer, either on an exophytic lesion or in a flat lesion, you think it may be inflammation, but it may be cancer. So you take biopsies. We take biopsies from this tumor. We see malignant cells invading the submucosa. So this is malignant transformation, and then we'll have surgery. Colectomy. We remove this part of the bowel with the cancer, and we stage the disease counting the lymph nodes in the subserosal fat tissue. Yes? Yes. The surface is ulcerated. The mucosa is not flat. It has a tumor, an exophytic tumor. However, the surface of the tumor is ulcerated. That's why you see it's not the same color in every place. Others are more red. Why? Because hemorrhage has performed, because it has ulcerated. This is a tumor with an ulcerated surface. When we talk of ulceration, we mainly think of a flat mucosa or the skin, and you see the loss of the covering epithelium and granulation tissue formation, and you say it's an ulcer. This is not a mucosal ulcer. This is a tumor, the surface of which has become ulcerated. Because if I ask you, what do you see here? You would not say I see an ulcer. This is not an ulcer. The ulcer would be if the mucosa was flat. This is a tumor with an ulcerated surface. And it is cancer, all right? And have a look at the patient's symptom. Microcytic anemia, hypochromic. Why? Due to the blood loss in the fecus, which was not evident grossly. You needed the test to find it. So anybody who has an anemia for some time should check the digestive tract. It's not necessary that it's a neoplasm, either benign or malignant. It could be inflammation as well, but you have to check. Don't take just iron, 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 iron. If it persists, you have to check the gut. Okay? Yes?
Can you please explain again the differences of invasion of adenomatous carcinomas in the large bowel?
Yes.
Where we find them and why they are...
We find atypical structures above the muscularis mucosae, entering the submucosa. This is the definition of cancer in large bowel. Anything that happens within the mucosa, either intraepithelially above the basement membrane or beneath the basement membrane, but in the lamina propria, not entering the submucosa, this is dysplasia. Okay? But the same thing you see as dysplasia. If you see it in the submucosa, it's cancer. Okay? So, next case. Here is a young man with chronic diarrhea, and he has lost weight. And you see the small intestine mucosa. What's the difference between the normal and the patient's? It's obvious. What does the small intestine mucosa of the patient lack? That is evident in the normal small intestine mucosa. What does it lack? Villi. This is, you know the disease? That you have to exclude gluten. Yes. It's celiac disease. Yes. So you have the diet and you exclude gluten and the villi develop again. And it can be related to dermatitis herpetiformis. That means it looks like herpes infection, but it's not so. It accompanies celiac disease. What do we see in this X-ray? Why are the bowel loops so much with all these air in them? The patient has a 3-day history of worsening abdominal pain. What is this? What is this? We've briefly discussed it previously. What is this? The loops are distended, and you see they are filled. How big? So what does this mean? And the patient has no stool, neither gas. What is this?
The necrosis of the bowel.
If you had necrosis, that would be different because it won't be so much distended. This is obstruction of the bowel, all right? If you had necrosis, you had severe pain, however, the bowel wall may have ruptured and you have peritonitis. This is obstruction, and so let's have a look at what is beyond the obstruction. If you have multiple lung nodules, what may have caused the obstructions in the bowel? What may have occluded the bowel lumen? If the patient has many lung nodules, what is the cause of obstruction in such case? What do you think in the bowel that caused the obstructions and is followed, is accompanied by large lung nodules? If we have many nodules in the lung, what did we say when we had the lung cases study? What did we say? You have multiple nodes, nodular lesions in the lungs. What are they most likely? What are they? Yes? Yes, please. What are they?
Petechial hemorrhage?
No, they are not petechial. There are many nodules in the X-ray. You cannot see it as a small microhemorrhage.
Could it be a carcinoma that
Metastasis. When you see large nodules in the lungs, they are most probably metastasis. So what has caused the obstruction? A tumor, a malignant tumor that has had also an exophytic component which occluded the lumen. Second possibility, she had prior abdominal surgery. In this case, what has caused the obstructions most likely? That he has a history of surgery in the abdomen. What may have caused the obstruction? The bowel is obstructed not only from the interior, but also from the exterior. So what can that be? The hernia is when a part of the bowel protrudes from the abdominal wall. That's what a hernia is. What can that be? That she had a surgery. What may have formed there in the peritoneum? Strictures. That is also a main cause of bowel obstruction. And the third case, the cecum and sigmoid. These are parts of the bowel which are not so well, how can I say it? They are not so well tied to other soft tissues. So they can turn around. They can turn around themselves. Which parts are most vulnerable? Cecum and sigmoid. And this is called volvulus. All right? Volvulus. And you have, of course, obstruction because the part of the bowel has turned throughout itself, twisting on the mesentery. And the other term, the non-mechanical obstruction, because all three cases were mechanical obstructions, either a tumor within the lumen, either strictures from the outside, either the volvulus. If there is no mechanical obstruction, however, the bowel cannot, the bowel content cannot move, in this case, we talk of paralytic ileus, paralytic ileus. No mechanical obstruction. What's the problem in this scan? What's the problem? We see the liver. You all see the liver? What do you see there between the liver and the abdominal wall? What do you see there? What is that? Fluid. How do we call the fluid accumulation in the peritoneal cavities? How do we call? Ascites. What do you think of ascites? You say, first of course, you have to take the fluid, have it centrifuged, and have a cytologic smear. If it is of inflammatory origin, it will be full of inflammatory cells, mainly neutrophils, if it is acute inflammation. If it is cancer, you'll find the malignant cells. Because if you have a cancer in some organ of the digestive tract, there is a possibility that, think of the stomach, neither the cardioesophageal junction nor the pyloric part. Think of the body of the stomach. In such case, obstruction cannot occur because the cavity is too big. So what does cancer do? It invades all the wall of the stomach, enters the peritoneal cavity, and blocks lymph drainage. So we have ascites, ascitic fluid, and it's full of cancer cells. So the first symptom of gastric cancer may be a sign of a very locally dispersed disease. In bowel, it's not so often. It can occur, but not so often. So it's not the same when you see this. Could this be related to cancer? Have a look. Apart from the fluid, all right, we found the fluid. What is all this black area here? What is this? What can this be? And it is air. That's right. It's air in the abdomen. Cancer can never do that. If the cancer affects the peritoneum, it gives carcinomatosis. And we have ascitic fluid. How can air be justified in the abdomen? How can air be justified? This is the rupture. This is the rupture. For example, he had an ulcer, a benign ulcer, either in the duodenum or the stomach. It was not treated to heal properly, so it went on and on throughout the gastric wall, and we had the rupture, and all the gastric contents entered the peritoneal cavity with air as well. That's why you see all the up area being. And this is a very dangerous complication, perforation, I think it's called, and you have to put the patient in surgery to treat his acute peritonitis. Okay? So, when you see the air, you don't think of cancer, you think that something has perforated, and look at all these diseases that may cause perforation and entrance of air in the peritoneal cavity. This is gastritis. Did you have the lesson of gastritis? This is the most common type, Helicobacter gastritis. It irritates the mucosal epithelium of the stomach and causes inflammation. This is one type of cancer that is poorly cohesive. That means cancerous cells do not form glands. They do not form glands. They are dispersed. And it's poorly differentiated, of course, high-grade cancer. Oh, this is another tumor, not of epithelial origin. However, it can protrude from the wall of the stomach where it is, it develops to the lumen, and it can become ulcerated. However, it's a gastrointestinal. This is not epithelial. It's a gastrointestinal stromal tumor. And here is the lower part of the esophagus. What's wrong with it? Do you see the expected squamous epithelium that lines the lower, all the esophagus? No. It has been metaplastic. And when you see goblet cells, this is Barrett's metaplasia, which is, all right, it's a lesion. But when such an epithelium becomes dysplastic, when it becomes dysplastic, it may give rise to an adenocarcinoma, because it's glandular metaplasia. So it gives rise to an adenocarcinoma. This is the case here. This appearing somehow velvet is what Barrett's esophagus looks like. However, this is another type of esophageal cancer of squamous cells. This is squamous cell carcinoma from the covering epithelium. This is herpes. Pay attention. Have a look at the history. He had pain when he swallowed the food. And what? He had a white blood count of 97,000. What is that? If you find this number of white blood cells, what do you think? Not so much. It's impossible. 97? 97? It can't be infection. Acute.
Sepsis, cancer, what is it?
That's why I say. That's why I tell you. All right, we read books. We know all that. You've done hematopathology, not with me. I don't say that because I do everything best. No, but when you do hematopathology, the previous semester, and you find such a high account of white blood cells, what is this? Say malignancy. This is leukemia. This is leukemia. That's why, what shall we try to do now in this semester? Now that you'll start your clinical practice in the next semester, you have to think simply, not too complex. No. When you find 1,000 white blood cells, it cannot be inflammation. It cannot be inflammation. It is leukemia. So how was the patient treated? He most probably had some medication that suppressed his immunity, and he got herpes esophagitis. And pay attention, because when the virus enters the squamous epithelial cells, this becomes atypical. Do not overdiagnose such a lesion as cancer, because squamous cells, when the herpes virus enters, they become atypical. This is not of malignant potential. This is degenerative atypia, which can be quite prominent. And if you do not take into account the patient's history, the macroscopic image of the lesion, what is the macroscopic image of the lesion? Pay attention, please. Round vesicles, endoscopically. Round vesicles. Does a carcinoma ever take this macroscopic lesion? Vesicles. What takes this form? Of course, you've seen the lip. If you see these vesicles on the lip, what do you think? Herpes. So you make a constellation of everything. Patient's history, macroscopic image, microscopic findings, and then you make the diagnosis. Because if they ask me, have a look at this image, what do you see? I see an inflammatory exudate and highly atypical cells. It could be cancer. No, it's not cancer. Because you have to relate what you see in the microscope with the patient's history and the macroscopic endoscopic evaluation of the patient. And the last, yes, we're finishing.
Where do we see the nerves here?
Where do we see the?
Herpes isn't attached to the nerves.
There are two types of herpes. This one affects the cells. I think it's type 1. I'm not sure. I have to read that. I have to study that. And the last The last image is this. It's another case of hematemesis. However, the problem is not in the stomach. The red blood that you see in the vomiting is related to hemorrhages in the lower part of the esophagus from large bleeding varices. What does the patient have? He has portal hypertension, so the blood must find ways not to pass from the liver. Mainly is a consequence of liver cirrhosis, portal hypertension, mainly, not always. So the blood enters the lower esophagus submucosal veins, they become distended, and when they rupture, they give hematemesis. And you have to act quickly and stop the bleeding, because the patient may have exsanguination and die. Especially, this is a complication of cirrhosis of alcoholic etiopathogenesis due to heavy consumption of alcohol. That's all for today. Okay? Bye.